Moving on to the next topic, would like to invite the chairpersons, Dr. Karunesh Kumar, HS, who's the consultant physician and diabetologist at Diabetes Medical Center, Bengaluru, and Dr. Ravi Kumar, YS, who's the professor and HOD, Department of Medicine, JSS Medical College, Mysore. We welcome you on stage, doctors.
Good afternoon. Heartily thank Dr. LSM for asking us to chair this session and asking me to be part of this very nice symposium. Two important compounds, both of being white, are ruining mankind till now. One is sugar, the other is salt. We have heard enough about sugar till now. And to highlight about importance of salt and salt sensitivity, we have with us a great speaker, Dr. Shashank Joshi. I don't think this audience needs introduction to this great person. I request my co-chair to introduce the speaker.
Good afternoon, everybody. It's my privilege and honor to introduce our esteemed speaker, Dr. Shashank Joshi, one of India's most distinguished endocrinologists. He is a Padma Shri awardee. He has played pivotal leadership role in Indian medicine, serving as President of the Indian Academy of Diabetes, past President of the Association of Physicians of India, past President of RSSDI, and Endocrine Society of India. He is also past Chair of the Southeast Asian IDF.
So thank you so much, chairpersons. And again, I would like to thank Professor L. Srinivas Murthy. And I'm happy that he kept this topic on salt matters in modern hypertension therapeutics. There is a duality and conflict of interest for this talk because IPCA, which makes ETD, is a sponsor of this talk. These are my disclosures. So why this topic matters? This topic matters because hypertension, global burden, is one of the largest on planet Earth. And most people on planet Earth die because of heart disease. And morbidity is also because of heart disease. Very clearly, there is a treatment gap. Most people living with hypertension remain uncontrolled despite of treatment. And one of the important reasons is sodium handling differs profoundly between individuals. Yesterday, Vitul was doing a very nice panel. And this part was not discussed. But if you are in Punjab or Haryana, if you are in a coastal area, if you are in Gaya, the ability to handle sodium will differ based on the sweat sodium, based on your urinary sodium receptor. So very clearly, there is a clinical relevance for the salt sensitivity, because salt sensitivity helps you to explain why standard hypertension care sometimes underperforms. That's the primary reason of that. So salt sensitivity is a tendency for blood pressure to rise or fall meaningfully in response to changes in sodium intake or sodium balance. Okay, it's not a rare curiosity. It's a very important clinical phenotype. And a large proportion of people are salt resistant, but few are salt sensitive. It matters in blood pressure and also matters beyond blood pressure, because it's not just a blood pressure reading which is high, but the outcomes long term, including mortality, are accounted for by the baseline blood pressure. And it's a risk phenotype. So clearly it's not a merely diet preference that I have to eat less papads, pickles, salt. Okay, that's what our chairperson was alluding to, and that's pretty right. But it's a risk phenotype which propels mortality. And therefore the central clinical question as clinicians, we are all clinicians, is why two patients with similar clinic blood pressure respond differently to the same sodium intake. You may have the different response. And the answer lies in the renal sodium handling, neurohormonal tone, vascular biology, and circadian sodium excretion. So our kidney, and I'll allude to that a little later, has a pressure natriuresis shift. Our neurohormonal tone is set by the sympathetic and renin-angiotensin axis. Our endothelial nitric oxide pathways determine our vascular resistance and make our arteries stiff or soft. And you know that there is a lot of circadian biological clock, and the nocturnal sodium burden is the one, and therefore salt sensitivity is a systemic disorder which even the American Heart Association, American College of Cardiology recognizes. So the lifestyle risk factors in hypertension, high salt intake is the highest, and almost 1/3 of healthy individuals and 50% of hypertensives have salt sensitivity. Indian prevalence is unknown, but older adults, African Americans, people with chronic kidney disease, people with diabetes and metabolic syndrome, and Indians are full of diabetes and metabolic syndrome, salt sensitivity is relevant. When there is excessive sodium on health, there is not only a cardiovascular risk, but there is an exaggerated effect, and therefore now the American Heart and American College of Cardiology recognizes salt sensitivity as an independent cardiovascular risk factor for disease and mortality. As I told you, the mechanisms get complex because of kidney, vascular function, the immune system, gut microbiota, and the impaired response to salt sensitive individuals are linked to the blunting of peripheral vascular resistance, nitric oxide production. So finally, we have increase of salt intake. But I also want to tell you that you can't make it zero salt. And this is a very good meta-analysis just published, that you need a little salt to motivate. You need a little salt to have the right insulin. And therefore, O'Keefe and Dinol made this very beautiful meta-analysis which said that we need low salt diets to lower blood pressure. But the unintended consequence of zero salt is worsening of insulin resistance. So this is the first paradox. If you have too less, you will not only faint and fall, but you will also worsen insulin resistance. Because the lack of sodium will make insulin to go up as a compensatory mechanism, because insulin will help the kidney to retain sodium. Our body will suddenly think that we are lacking sodium, and that is how the kidneys respond. So low salt diet also elevates stress hormones. They cause vessels to become stiff. Indians have very stiff arteries. And one of the links of vascular stiffening and systemic insulin resistance is linked to that. So remember, zero salt is not our goal. Because too less salt also increases cardiovascular mortality and events are seen. So look at human studies of low salt diets on markers of glucose and insulin resistance. There are several studies, and I will not go into details of them, which have shown that you can get insulin resistance because of activation of sympathetic nervous system, renin-angiotensin system, volume depletion, increased NEFA, and low intracellular sodium concentration, which improves the glucose uptake in the intestine. So when there is zero salt or no salt, there is worsening of insulin resistance, there is worsening of lipid biology, blood viscosity, creatinine, uric acid and kidney function, and activation of sympathetic nervous system, outweighing the blood pressure lowering effect. And therefore, eating a diet consisting of whole foods, maintaining a normal sodium intake may be a better option for metabolic health and blood pressure. So if your salt intake is less than 2 grams per day, you should use it cautiously because you may also have an adverse event. Unfortunately, globally, the cardiovascular mortality is linked to sodium consumption. In the South Asians, excess salt intake is the 7th largest cause of mortality, and it causes a lot of death, but we eat too much salt. Highest salt consumption, Vitul, is in North India, 14.13 grams per day. We are a salted nation. Okay. Even South and West is 9 grams. It is too much. You forget 4 grams. We look at the papads, the pickles. If the food is made bland, you know, you will put andas on Srinivas Murthy, you know. Everybody is looking forward to the food and lunch after the oration of Dr. Rai. But very clearly we recognize that salt is the biggest cause of wars. Now, of course, that salt has become crude oil. Okay. But in the good old days, the word salary came from salt. Because salt was a trade. Preservation, all ultra-processed foods, all refrigerated foods have nothing but salt. if you eat refrigerated food, if you eat preserved food, you will have too much of salt, hypertension, and you will die early. And we are having too much of salt. So very clearly we need to recognize that we need to reduce it, because our salt intake is 5-fold to 6-fold higher compared to normal diet. And all the foods we eat, including in these Four Seasons hotels, is all processed foods, restaurant foods, and all we are doing is creating hypertension and dying early. Very, very clearly. And I think we need to recognize that too much of salt is very, very clear. So instead of having your cucumber, tomato, soy chicken and potato, we have pushed them into a pickle, into a pasta sauce, into a potato chip. And therefore we need to avoid that. Intersalt study, which Salim Yusuf and his group did very nicely, we just have had too much of salt worldwide in across communities, and it increases blood pressure. But clearly there is a relationship to salt sensitivity. And there are different theories recognizing it. There are different mechanisms of salt hypertension. And in that, there is a clear-cut linkage with two hypotheses. I'm not going to dwell with all hypotheses. There is something called as the old hypothesis, which is the kidney theory of salt sensitivity. And the second is the vasoconstriction theory. The old theory or the kidney-centric theory is when there is high blood pressure, it allows pressure natriuresis, pressure to pee and pour out sodium with the intake. And when the intake is not equal to excretion, due to low nephron numbers, like aging population, female sex, low birth weight, small for gestational age, hypertension and CKD, low potassium diet, African ancestry, Asian ancestry also we can add, low renin status, and genetic defects of the epithelial sodium, then you will get salt sensitivity. The newer theory is vasoconstriction theory, which means when there is high blood pressure, it is a consequence because of stiff vessels. We are not soft, we have hard, stiff vessels. If we talk to our friend Dr. Bonder in Ludhiana, he will tell you that we have stiff arteries and small arteries. We have Dr. Manoria from Central India and Bhopal, who's a world famous cardiologist. Again, the consequence of incapacity to vasodilate after sodium load is a hallmark in the Indian population because of endothelial dysfunction, the endothelial glycocalyx being perturbed, the high vascular sodium milieu, inflammation, and a disturbed sympathovagal balance. So that is very clear cut. And it's all linked even to gut microbiome, interleukin 17, monocyte macrophage system, lymphatics, and finally it comes down to our sweat glands in the skin where there is an epithelial sodium receptor. And therefore that shift to left to shift to right, whether you are going to be salt sensitive or resistant, is going to be relationshiply driven by volume loading, vasodysfunction theories, and so on and so forth. And therefore we have multiple mechanisms of the theories. Now many populations, like Chinese, Tibetan plateau populations, have a genetic variation of hypertension, and they are salt sensitive. So we need to recognize that we need to do more research in this area, and we also recognize that there are non-modulators. So we need to, just like non-dippers, find out who are the non-modulators of salt sensitivity, and therefore we need to have a strategy to prevent salt sensitivity and salt-induced hypertension, and there's a lot of linkage with that. It's also genetic. For example, there are different genes in the kidney which alter renal sodium transport. There are different genes which alter vascular reactivity in the vessels. So either it is kidney or the vessels which predispose you to salt-sensitive hypertension, and probably it all starts in the fetus or the elderly, where maternal malnutrition will modulate the renal mineralocorticoid receptor, the vascular renal blood flow, the renal sympathetic nervous system, and the net result is impaired renal sodium handling, leading to sodium sensitive, salt sensitive hypertension. It could be a bradykinin pathway, it could be sympathetic overload, it could be sympathoactivation, but does it translate into data? If you talk to cardiologists, they will say we need outcomes. We need population studies. We need long-term studies. And I am showing you two very good data sets to prove this point. Why the American Heart, European Heart, Japanese Society recognize salt sensitivity. You know, Japanese people are fish-eating people, but also salt-eating people. This is a Japanese study of a follow-up of 20 years, showing that salt-sensitive people have more cardiovascular events compared to non-salt sensitive people. And in United States, these are survival curves over 30 years of follow-up. Again, outcomes with 30 years, that people who are salt resistant survive better compared to salt sensitive people. So it matters whether you are salt sensitive or salt resistant. And that data plots are very, very well plotted because they are linked to vascular resistance, cardiac output, and sodium balance. Can we measure it? Well, it's not easy to measure. You can do a urinary sodium to potassium ratio. It's a reliable indicator for cardiovascular risk and CVD-related mortality rather than measuring sodium or potassium intake individually. It is a predictive value, and therefore you can measure it and you can avoid the 24-hour urine collection without any loss of urine, and you can self-monitor it. And if it is more than 3 times a day, it may be effective lowers salt intake, and you can actually look at that possibility. Particularly, these studies have been done. So measuring salt sensitivity in real practice, you have to do a formal salt loading and a depletion protocol. That's not possible in routine clinics. So you can do ABPM, and if it reveals a nocturnal load, dipping status, nighttime hypertension burden, there's an indirect suggestion you are salt sensitive. If you respond to sodium restriction, it probably is a clinical proxy to understand that you are salt sensitive. But of course, the best practical biomarker is to look at 24 hours urinary sodium. And in this clinical context, if you are a diabetic, CKD, dipper status, it is inferred and it's still useful to know that you are probably salt sensitive. So the practical role of 24-hour urinary sodium is not very easy. It's a practical biomarker, but as a measurable intervention, it is not easy to counsel these people. ABPM is much more valuable because it goes beyond white coat. It detects the salt and the sodium overload, and it's a good phenotyping tool. But you can reduce salt, and there's data to show that it reduces the blood pressure. In the CKD in South Asians, there are RCTs available because we also want RCTs in that population. DASH diet, we know the data, and also there is animal and human data to show that some of the micronutrients like potassium and other vitamins may have a role in salt sensitivity, and that data is clear-cut. So how does the American Heart and American cardiologists view salt sensitivity? As a marker for increased CV risk. Current recognition techniques are impractical for routine use. We need dietary sodium restriction, but we need to have a deferred hypertension protocol. And to treat salt sensitivity hypertensive, there is no consensus, but diuretics may have a role. And when they did a network meta-analysis, clearly they looked at where the actions are. It's all in the nephron and it's all in the diuretics. Because diuretics have been shown, particularly chlorothalidone, that they have a role in salt sensitive, and probably the ALLHAT results which improved mortality are linked to that. And this is very well studied in people with metabolic syndrome, in diabetes, in CKD, and therefore it's not surprising that the outcome data is very positive, and thiazide-like diuretics now therefore are endorsed like chlorothalidone over thiazide diuretics because they have data, and therefore even ADA now recognizes that you need to have thiazide-like diuretics, which is like chlorothalidone or indapamide, because they are longer-acting diuretics. They have proven CV risk reduction. They have different mechanism of action, pleiotropic effect. Also in CKD, there is a case for chlorothalidone, and therefore all the recommendations of adult CKD patients in hypertension management have a role for diuretics. The Europeans have recognized it, and so have the ESC. So whenever you have true resistant hypertension, you can see that. But we have been obsessed as diabetologists and endocrinologists with ACRB and CCBs. But if you see the ADA 2024, there was a change. They added diuretics as an equal partner, and they clearly said that you need to add a thiazide-like diuretic. And even Dr. Makkad is right here. When he was the president, they came out with a guidance for RSHDI of hypertension, and Vasant Kumar, Dr. Agarwal and Bansi, and they said thiazide-like diuretics like chlorthalidone demonstrate superior blood pressure reduction. WHO has also endorsed the same, and therefore it's not just A and B and C and D, the diuretics are equally important. And JNC 8 in 2014 had said diuretics are important. So I had to make only one simple point, that we need to reduce salt intake to less than 5 grams per day. That's a given, but not less than 2 grams. So you need between 2 to 4 grams of salt per day. Second, when you're treating people, including diabetics, don't forget thiazide-like diuretics. Because you can save a lot of lives, there's outcome data, and fundamental to human life is circadian biology. So please do an hour of digital detox. Please look at health and happiness outcomes, but don't forget sodium, salt sensitivity, salt intake, and diuretics. Thank you so much for a patient hearing.
Thank you, sir. That was a wonderful talk on salt sensitivity and its role in hypertension. The floor is open for questions. One question, because we are running out of time.
Yeah. So, in your consultation room, patient comes with hypertension, diabetes, multiple cardiac issues. When you give a prescription for salt, in a given patient, how do you decide whether it is salt sensitive or salt resistant? In a given patient.
So as I told you, in a given patient, to identify salt sensitivity is very difficult. Either you have to do a urinary sodium to potassium ratio, or collect 24-hour urine and do a salt loading or salt depletion test, which is usually done in research protocol, which is why all associations do not recommend it as a standard of care. But if you are having facility to do a 24-hour blood pressure monitor, there is a night dipper, it is presumed that this person is salt sensitive. So whenever there is an exaggerated response, whenever there is a resistant hypertension, the one of the key cogs in your blood pressure management could be salt. Our problem is we eat too much of salt. We don't need to have a zero salt. We need to have just right amount of salt.
Sir, lot of buzz on pink salt.
Sorry?
Pink salt.
Himalayan pink salt.
Pink salt and all is a food product. Okay, there is no iodized salt in it. You know, there is just a fashion. Okay, there are low sodium salts, which have potassium, which are ethical. Okay, but these non-iodized salts claiming health benefits have no biological basis, because that is salt only. Okay, so that is sodium only. But there are low sodium salts where they have replaced salt with potassium, and they have a restriction, and low sodium salts are available in India, and we should move towards low sodium salts, but they are not easy to get. They are a little more expensive. Salt is a very cheap commodity. The non-iodized version has been nicknamed as the pink salt or the rock salt or the Jada salt, and sometimes we use it when we want to have an iodine-free diet, if you want to do a nuclear thyroid scan. But beyond that, if somebody has a thyroid cancer, there's really no role for these type of salts, which are pink salts and all. Pink salts are looking as a very attractive term, but their sodium content in that is the same. In fact, they can precipitate heart failure. There's data to show that if you use the traditional rock salt, it is volume loading and causes heart failure.
Sir, the world bodies recommend a maximum salt intake of 5 gram per day or 2.6 gram protein, sodium per day. But there is no recommendation for minimum amount of salt. What's your?
So I told you that you need to probably take at least 2 grams of salt per day, because that data is now better and available.
Thank you, sir. Thank you for your...
Thank you so much, doctors. We request the chairpersons and speaker to move to the selfie area, which is just outside the hall.